A very good morning to all. I'm present here. I'm Dr. Durga, Associate Professor, Department of Obstetrics and Gynecology, SLIMS. I'm here to take a video lecture on medical termination of pregnancy and sterilization. On the background, national consensus for medical abortions in India. Every year, about 11 million abortions take place, of which 20,000 women die due to abortion-related complications, most of which are illegal abortions. The Medical Termination of Pregnancy Act addressing a public health priority. MTP Act, an enabling act which aims to improve the maternal health scenario by preventing unsafe abortions, thereby decrease the high incidence of maternal mortality and morbidity. It legalizes abortion services. It promotes access to safe abortion services. It decriminalizes the abortion seeker, offers protection to medical practitioners who otherwise would be penalized under the Indian Penal Code, Section 315 to 316. The MTP Act, the legal status. It was first enacted in 1971, implemented in the year 1972, and amended in the year 1975. It lays down when and where pregnancies can be terminated, grants the central government power to make rules, the state government powers to frame the regulations. In the year 1994, sex-selective abortions, giving or taking prenatal test solely to determine the sex of the fetus, criminalized by Indian law. The Medical Termination of Pregnancy Act Amendment 2002. It stiff penalties for sex-selective abortions, up to 3 years of imprisonment and rupees 10,000 fine first, and up to 5 years of imprisonment and rupees up to 50,000 fine for the second. World lunatic replaced by mentally ill person. No medical termination of pregnancy should be done at any place other than a hospital established, maintained, approved by the government. MTP by a person, not a registered medical practitioner, punishable with rigorous imprisonment of 2 to 7 years. Abortions are termed legal only when all the following conditions are met with. Termination is done by a medical practitioner approved by the Act, at a place approved under the Act, and for conditions and within the gestation prescribed by the Act. Other requirements of the rules and regulations are compiled with. When can pregnancies be terminated? It can be terminated up to 12 weeks of gestation by a registered medical practitioner. No pregnancy termination without the consent of the woman can be done. If the woman is less than 17 years, or if she is greater than 18 years but a mentally challenged and ill person, a consent of the parent or the guardian must be obtained, with the opinion of a registered medical practitioner formed in good faith under certain circumstances. But if there is an absolute essential opinion of 2 registered medical practitioners when the termination of pregnancy is done between 12 to 20 weeks. But now the recent guideline says that the pregnancies can be terminated up to 24 weeks under certain circumstances. When can pregnancies be terminated? Continuation of pregnancy constitutes a risk either to the life or a grave injury to the physical or the mental health of women. Substantial risk of physical or mental abnormalities in the fetus as to render it seriously handicapped. Pregnancy caused by rape, which is presumed grave injury to the mental health of the women. So, contraceptive failure in a married couple presumed to cause grave injury to the mental health are the conditions where the pregnancies can be terminated. According to the MTP Act, where this MTP can be conducted, it can be done by a hospital established or maintained by the government or a place approved for the purpose of this act by a district level committee constituted by the government with the CMHO as chairperson. Implications of amendments simplifies registration of sites which can be done at district level now. Providers can get test sites approved for providing abortions under the MTP Act for the first trimester only or up to 20 weeks and thereby come under the protective cover of the MTP Act. The MTP rules, what are they for? Enable proper implementation of the provisions of the Act. Ensure that MTP services are provided by qualified persons in safe and hygienic settings. It helps to monitor the quality of services. In MTP rules, what do they cover? Experience and training required for providers, approval of a place for termination of pregnancy under the Act, composition and tenure of district level committee, inspection, cancellation, or even suspension of the approval can be done, and a consent form is required. Who can perform? A registered medical practitioner, that is an RNP, as defined in Clause H of Section 2 of Indian Medical Council Act of 1956, whose name has been registered in the State Medical Council and who has such experience or training in gynecology and obstetrics as prescribed by rules made under the Act. For termination up to 12 weeks, a practitioner who has assisted a registered medical practitioner in performing 25 cases of MTP, of which at least 5 performed independently in a hospital established or maintained or a training institute approved by the government. This is the MTP rules training requirement 1. Training requirement 2 for the termination up to 20 weeks. A practitioner with experience in ONG for at least 3 years if registered before the Act. If registered after the Act, completed 6 months house job in obstetrics and gynecology and at least 1 year experience in OG at a hospital which has all facilities, or a postgraduate or a diploma in obstetrics and gynecology. The approval of a place by trimesters for sites up to 12 weeks, gynecological examination and labor table is essential. Resuscitation and sterilization equipments, drugs and parenteral fluids, the backup facilities for any treatment of shock, and facilities for transportation. For sites where termination is done up to 20 weeks, that is to the end of second trimester, all requirements for up to 12 weeks plus an operation table and instruments performing abdominal or gynecological surgeries, anesthetic equipment, resuscitation equipment, and sterilization equipment. Drugs and parenteral fluids notified for emergency use are notified by Government of India from time to time. The regulatory body, the district level committees, minimum of 3 and maximum of 5 members, including a chairperson. And the composition of the committee is 1 medical person, a gynae, a surgeon, or an anesthetist. 1 member from the local medical profession, an NGO or Panchayat Raj institution of the district, and at least 1 member shall be a woman. The tenure is for a calendar year of 2. An NGO member should not have more than 2 terms. Approval process. Application in Form A to be addressed to the CMHO by place seeking approval. CMHO verifies or inspects the place to satisfy that termination can be done under safe and hygienic conditions. The CMHO recommends approval to the committee, and committee considers application and recommendation and approve and issue the certificate of approval in Form B. So this is an application form called Form A, which is given in the vernacular language or the local language of that area. The approval process: places to be inspected within 2 months of receiving the application and certificate to be issued within 2 months of inspection. If deficiency found within 2 months of deficiencies, it has to be rectified. The CMA chose to inspect to ensure the safe and hygienic conditions for conduction of medical termination of pregnancies. Call for information and cease in case found otherwise. The cancellation and suspension: the CMA chose to report to the committee for unsafe and unhygienic conditions. The committee can suspend or cancel the approval after giving the owner an opportunity for representation. Owner can reapply to the committee after making additions and improvements. During suspension, the place be deemed as not approved. Power to states to make regulations regarding MTP services. Regulations for union territories by central government. Applications of central government regulations in the absence of state regulations. Forms to be required for making opinion, administrative register and reporting of MTPs, custody of forms and prevention of disclosure of informations. The MTP regulations and opinions and forms. For an MTP, opinion of an approved RFP, a registered medical practitioner, when 2 for a second trimester abortion is required, the provider is required to certify his or her opinion in Form 1 within 3 hours of termination of pregnancy. MTP using mifepristone IU-486 and misoprostol approved for up to 7 weeks termination. Only a registered medical practitioner as defined by the MTP Act can prescribe the drugs. Has to follow the MTP Act rules and regulations and prescribe in his or her clinic, provided he/she has access to an approved place. Should display a certificate from owner of approved place agreeing to provide access. So, having discussed about the areas where we have to, how we have to, and what are the conditions and what are the prerequisites for doing a medical termination of pregnancy, it has to be carefully be done. So, depending upon for the methods we use for termination of pregnancy in the first trimester. In the first trimester, the common methods of MTPs are the medical methods, which goes by mifepristone and misoprostol. Mifepristone IU-486, it is an antiprogesterone agent. It is given in dosage of 200 milligram 48 hours after that dose of mifepristone. Per vaginal misoprostol tablet can be kept 800 microgram as a single setting, or it can be repeated as 2 doses of 400 milligram. There are also other ways of medical termination of pregnancy by using other drugs. Surgical methods are there by doing a suction evacuation or a manual vacuum aspiration or a MVA or an MR syringe. The second one, termination for a second trimester. Termination for a second trimester, even up to 14 weeks, this mifepristone misoprostol procedure can be followed. But in cases when the pregnancy is a little bit advanced, it's better to go for termination of pregnancy with cervical whitening agents like misoprostol or sabiprime, and later on proceed with the termination of pregnancy. We should know what is called female sterilization. Female sterilization is a permanent method of birth control where both the fallopian tubes are partially excised and occluded with a ring or a clip. The advantages: it is permanent, highly effective and safe, quick recovery, lack of significant long-term side effects, it's cost-effective, partner cooperation is not required, and it is not coitus linked. For the sterilization procedures, we have postpartum, otherwise called different sterilization, post-abortive, the spontaneous and the induced, the concurrent, which is called the concurrent, which is done at the time of an NSCS or an MTP or an ectopic or any other surgical procedures or an interval sterilization. Methods of sterilization, mini lab. that is puberal sterilization, interval transabdominal tubectomy, or MTP with TAT, or post-abortive TAT. Laparotomy concurrent with LSCS, ectopic, or other surgical procedures like hernia repair. A laparoscopic sterilization could be an MTP with lab or an interval lab sterilization. Timings of sterilization. The postpartum and concurrent with labs LSCS, puberal, greater than 48 hours within 1 week, and complicated cases. Within 1 week, on special situations like anemia, PH, heart disease, outside. So within 1 week, the puberal sterilization has to be done in uncomplicated cases. Interval sterilization 6 weeks after postpartum, post-menstrual phase of menstrual cycle. Post-abortive first trimester, it could be concurrent, but for the second trimester, spontaneous emission next day, provided no signs of infection is present. Now, what are the types of anesthesia? It is a total intravenous anesthesia. Can be used in PS or an interval TAT or a lap ST. Regional or spinal is required in an MTP with a TAT or an LSCS with TAT or sterilization and ectopic with TAT. General anesthesia is preferred for complicated cases like in heart disease. Pre-operate preparations. Case selection is important. Clients married with 2 healthy children, 1 living child of 1 year of age 22 years and above. Spouse are not sterilized and clear state of mind. Counseling, informed consent, and checklist. Client assessment and screening. History, medical, menstrual, and obstetric history is obtained. Contraceptive history is obtained. General examination, systemic, and local examination must be done. Investigations, blood, hemoglobin, urea, sugar, urine for routine ultrasound, ECG, and echo if needed. Providers for performing sterilization. The mini lab services, MBBS trained in sterilization procedure. Laparoscopic sterilization, DGO, MD, MS trained in laparoscopic sterilization. Technique with procedure. Ensure bladder is empty. Void catheterize. Incision 2 to 4 centimeters. Transverse or longitudinal. Occlusion of tubes 2 to 3 centimeters from the corneal end and 1 centimeter of the tube to be excised. 3 centimeters from the corneal end. No crushing or no cautery. Only occlusion of the tubes is done. Okay, 2 to 3 centimeters from the corneal end. Lab sterilization, 2 fellow rings in each tube. You have to put 2 fellow rings. Formulaic method, the most popular method of tubal ligation. Method, local anesthesia with sedatives, fallopian tube identified on each side and brought out through the incision. Instrument portion formed into a loop. Tubal excised and ligated using square mount with 1,0-chromic catgut. Excision of at least 1 centimeter of instrument portion causing cautery. Crushing to be avoided. Lab sterilization, monopolar coagulation, proposed in 1937 by Anderson. Complications, bowel burn, bleeding, long portion of the tube is damaged, failures, and ectopic from pregnancy. Transection is frequent. Laparoscopic sterilization, bipolar coagulation, introduced in 1976 by Jacques Rioux. Most common method of laparoscopic sterilization, burn several locations along the tube. Complications, formation of retroperitoneal fistulas, high rate of ectopic pregnancy, potential for bowel burns, and reversals are potentially more difficult with the extent of the tube damage. Laparoscopic sterilization, where you see the fellow ring, which is attached to the ring applicator, and this fellow ring has been attached down. And this is a tube which is seen here, right? So this is the failure rate of lab sterilization by fellow rings, always called the Yoon band, is 17.7 per 1,000 population, which is about 1.8% failure rate. Mechanical occlusion invented 1974 and tubular occlusion accomplished by placing a silicone band around the tube in a similar fashion to a Formulaic technique. Thicker tubes may be problematic, may not be suited for postpartum complications, increased patient discomfort during recovery, a large area of necrosis. So this is a view of the human band, otherwise called the fallopian, which is placed the tube. IV fluids, 2 units are given post-operatively, and oral fluids can be started by the evening and normal diet from the next day with antibiotics and analgesics. So what are the advantages and disadvantages of lab sterilization? Lab sterilization advantages: subumbilical scar, small and nearly invisible. Short general anesthesia and local anesthesia. Minimal hospital stay, about 70% is reversible. Minimal post-op pain and discomfort. Disadvantages: equipments are expensive. Maintenance are not easy. Requires specially trained personnel. Laparoscopic sterilization. Contraindications: cardiac, pulmonary, and disease, previous abdominal surgeries, puberal causes, extreme obesity, diaphragmatic or umbilical hernia, PID. The Government of India has forbidden laparoscopic sterilization combined with the second trimester MTP and a puberal period. Lab sterilization the next day, mini lab, third post-operative day. LSCS with the sterilization, ninth post-operative day after suture removal, the patient is discharged. The follow-up advice. Mini laparotomy. In mini laparotomy cases, to come after 1 week for suture removal and then 1 month later for review. In lab LSCS with sterilization, after 15 days for review, they have to come. Warning signs, if any, to report immediately: fever, vomiting, acute abdominal pain, dissension of abdomen, bleeding, or discharge from the wound or vagina should be reported. What are the medical visits to return? In first week, come at once. If there is high fever or pus or bleeding from the wound, pain, heat, swelling, redness of the wound, steady or worsening pain, cramps, tenderness of the belly, fainting or very dizzy. At any time in the future, come at once. If you think you may be pregnant, pregnancy after sterilization is rare. If occurs, it is usually ectopic. 20 to 50% of it is ectopic. Pain or tenderness in the belly or fainting must also be reported. Difficulties encountered during surgery: bleeding from vessels in mesoovarium and ovary, difficulty in delivering the tubes, short tubes and tight abdomen, difficulty in access to the tubes. In places of dense adhesions and straining and pushing the bowel, accidental injury to the bowel and bladder. What are the complications? Immediate complications, though rare, are paralytic ileus. Delayed complications are stitch abscess and wound sepsis, whereas remote complications are incision hernia, abnormal uterine bleeding, which we call it as post-ligation syndrome, and spontaneous tubal recanalization and scar endometriosis. Post-ligation syndrome, the result of a rapid decline of estrogen and progesterone hormone levels caused by the blood supply being damaged to the ovaries during the tubal ligation surgery. The pelvic pain, regular periods, and mood swings. Studies and findings. Sterilization, a review of world experience. The method used, like bipolar, unipolar, mule band, or fallopian, uncouplet, and internal partial saprophyncectomy. The failure rate was found to be in bipolar, it was about 2.48%. Unipolar 0.75. Fallopian is somewhat much more higher as 1.77. Halka clips were even more higher as 3.67%. And even a partial self-injectomy, we have a 2% chance of failure rate. So none of the sterilization procedures are going to help you with a 0% pregnancy rate. Depending upon the open methods like polymerized method, bipolar cautery, or the Fisher clips, we found polymerized method is 1.5% failure rate, bipolar 17 point, so it's 0.75% polymerized rate, whereas when compared to the previous slides where the fallopian, the failure rate is 1.77%. Bipolar cautery is 2.4 and Fisher clips is 0.22. The main thing is always there is a risk of ectopic pregnancy after sterilization. Hysteroscopic techniques assure micro insert, approved by FDA in 2003. The tubal canalization and placement of intrafallopian flexible titanium micro insert in the proximal section of each fallopian tube lumen. Local anesthesia. The implant subsequently triggers a benign tissue response and occludes the fallopian tubes, resulting in tubal plumb. It is confirmed by HCG, hysterosalpingogram 3 months later. So this is an Escher, a micro insert which is placed inside the fallopian tube. Another hysteroscopic technique is the DNR, which is a procedure where the catheter delivers low radio frequency energy for 1 minute, then a 3.5 millimeter non-absorbable silicone elastoma matrix is placed in each tube lumen. 3 months of alternative contraception until HSG procedure confirms occlusion. The risk of hysteroscopic sterilization. We have expulsions of the device, perforation, misplaced device, pelvic or abdominal pain, altered menstrual flow, back or leg pain, and infection. Talking about a few words with male sterilization. Vasectomy, dividing the vas deferens and disrupting the passage of sperms. Incisional, it's conventional. No scalpel technique is preferred. 1. It was developed in China, introduced in the US in 1988. The time taken is only 10 minutes procedure and it's an OP procedure. Improved anesthesia. Clinician holds tubes in place under the skin. 1 puncture, no stitches needed. The client instructions given before vasectomy is to have a bath before 24 hours. Scrotal bath should be taken after 24 hours. Scrotal support and the rest for 2 days. Bandage for 3 days. And for pain, take analgesic tablets every 4 to 6 hours with application of ice packs. Do not scratch or pull the whip or lifting heavy weights and hard books for 3 days. Avoid sexual intercourse for 2 to 3 days until comfortable. Use condoms or any other family planning methods for 3 months or after 20 ejaculations. Return after 3 months for a semen analysis. The newer techniques are chemical sclerosis with 90% ethanol and 3.6% formaldehyde, silver nitrate, hydrogen peroxide, acetic acid. Advantages: it eliminates the surgery and is effective and quite easily administered. Occlusive plugs and intravasal devices still in experimental stage. So far we have dealt what are the rules and regulations of medical termination of pregnancy. We have also dealt with the techniques involved in medical termination of pregnancy, which is done up to 20 weeks, but now the recent guidelines is up to 24 weeks. 2 registered medical practitioners is involved in giving the opinion for the conduction of MTPs in approved centers. Going on to sterilization techniques, we were talking about 2 methods. One is your interval sterilization, the pubertal sterilization, in male sterilization and female sterilization. Among the event, the one thing which has to be given a proper education to the patient is that even though that the patient is sterilized, either the male or the female, there is always a chance of pregnancy. When most in females, the incidence of pregnancy, even with the best of all the surgical messages, even if you remove one half of the tube, there is a problem that the patient may become pregnant, or even if the full tube is removed, there are still chances that the patient can become pregnant. And those pregnancies should be looked into caution because most of them, they would be ectopic pregnancy. Hence, the patient should be advised that after sterilization, it's not always a guarantee, and there is about 2% risk of getting pregnant. The next thing is if she misses her periods and before she was regularly menstruating and after the sterilization, there could be some abnormal uterine bleeding, either oligomenorrhea or heavy menstrual bleeding. But the important thing is if she misses her regular cycles, it should be advised to her to do a urine pregnancy test and find out whether she's pregnant or not. And if she's pregnant, there is always a 90% chance of which could be an ectopic pregnancy. So this education must be taught to them. And in male sterilization, which is found to be a very good equal counterpart to the female sterilization, which is a no scalpel technique, which is done. And other chemical methods of sclerosing agents, which could be injected also, will help in sterilization. Moving on to the female sterilization, nowadays laparoscopic sterilizations are being preferred, but the chance of pregnancy with laparoscopic sterilization and with open methods of sterilization are more or less the same. So it depends upon the convenience of the patient and the expertise of the gynecologist or the obstetrician to do a medical termination of the pregnancy with laparoscopic methods. The next important thing is regarding the consent for sterilization. It is not essential for the male partner to give consent for sterilization. It is solely the consent given by the female is enough. But the age group of the male and the female should be documented. It should be minimum about the age of 24 years. And there should be minimum of 2 children, and the last childbirth should be at least 1 year. Then we were discussing about this hysteroscopic sterilization, which was a newer one, where radio frequency waves are being sent through a falloposcope or through a hysteroscope and then through a falloposcope into the uterine tubes, causing scarring, excessive scarring and ablation of the fallopian endometrial lining and thereby causing fibrosis. The other one is your hysteroscopic technique with echo or micro insert, which is laser and causes extensive inflammation and scarring and occlusion of the fallopian tube, thereby preventing any intrauterine pregnancies. The next important thing I want to stress here is the fellow rings, which have been now at the Yoon bands, which have been practiced everywhere for lab sterilization. The failure rate of this is also 1.77%. Compared to your formularized method, where the failure rate is 0.75%. What is formularized method? Where we do clamping, you make a loop of about 1 centimeter of the fallopian tube at the ischemo-ampullary region, right? Make a 1 centimeter tube and make a knot with the catgut or vicryl over the lower base. You clamp it, you ligate it and cut it, and the free ends of it are either clockwise or then separately sutured. That we call it as the formularized method. It's a modified formularized method. It's just cutting, clamping, and ligating. There's no crushing of the tubes which are left behind. So far, I think the basics of this MTPs and the sterilization techniques have been discussed. Hence, thank you.